I often say that the voice is the most personal of all art forms, and it's sort of inextricably linked to self-identity. That is how we present ourselves to the world, that we connect with others, that we commiserate with others, empathize, right? All of these things we do using our voice. Yeah, there are many, many tears shed in my office. It's a really, really vulnerable space, I think, especially, again, as you said, the stakes couldn't be any higher when our livelihood depends on it. This isn't something you can sort of look at like a violin, right? And be like, oh, I just need to get this tuned, or I just need to get this, string re-strung, or I need an upgrade, right? I just need to trade it in. No. This is the one and only set of vocal folds we have, and the level of grief associated with any sort of difficulty with the voice cannot be underestimated.
Welcome to Speaking of Talking. Hi, I'm Jenni Steck, voice and speech coach and total voice nerd, here to explore all the ways our voices shape how we connect, lead, and show up in the world. Each week, we'll chat with inspiring leaders, speakers, and experts from all kinds of industries. People who use their voices to move audiences, rally teams, and make an impact. From polished political speeches to spontaneous sideline interviews, we'll break down what works, what doesn't, and why it matters. At Jenni Steck Voice and Speech, we've spent the last decade coaching Fortune 500 executives, broadcasters from CNN, ESPN, CBS News, ABC News, and even prepping Hall of Fame speeches for the NFL and Major League Baseball. And now, I get to bring those conversations and insights straight to you. So if you love talking about talking, you're in the right place. And be sure to subscribe to Speaking of Talking wherever you get your podcasts so you don't miss an episode. And check the show notes for helpful tips and tools. I'm so glad you're here. Let's get talking. You guys, today I'm talking with Dr. Lesley Childs. She's a laryngologist and an associate professor at UT Southwestern Medical Center here in Dallas, where I am. She also serves as their medical director of the Clinical Center for Voice Care. And her team works with patients across a full range of voice disorders, from nodules and polyps to paralysis, spasmodic dysphonia, and the condition that we're going to be talking about today, which is muscle tension dysphonia. She also happens to be a classically trained soprano who recorded for Walt Disney recordings, voicing characters like Mulan and Sleeping Beauty. She's been at UT Southwestern for close to 15 years, and full disclosure, she and I used to work together there. I was one of their voice therapists for a little bit. She's also co-authored and published research on treatments for muscle tension dysphonia, including clinical trials on two of the most common therapy approaches, and we'll get into that. In this conversation, we also talk about what muscle tension dysphonia, or MTD, what it is, what triggers it, what the diagnosis actually looks like, and what it takes to get better. And then we also spend real time on something that doesn't always make it into the clinical conversations, which is what happens to a person's sense of self when the voice they rely on stops working the way it should. Let's get talking. My guest today is Dr. Lesley Childs. You and I have known each other for a while, although we haven't worked together in a hot minute. But just to give our listeners a little bit of background on you, some things that I know about you, I just want to take a second to talk about your background, because I think it's really going to set the stage for the conversation we're going to have today about muscle tension dysphonia. You're a laryngologist, and you're going to explain to us what that is. And you're an associate professor at UT Southwestern. You serve as the medical director of their Clinical Center for Voice Care here in Dallas. You're classically trained soprano, which I don't know that all of your patients know that about you, but I think it gives you such an interesting insight into what people are going through. And I want to hear a little bit about your recording with Disney. That's super cool. And I know when my girls were younger, we were way into all of those recordings. And reading your story, I don't think you and I really talked about this before, but it was a visit to an ENT when you were in high school that kind of led you down this path. And then I think from what I've been reading too, I didn't realize you had done a lot of research into muscle tension dysphonia specifically and some of the treatments that are out there. So I can't wait to talk to you about your findings and recommendations. I didn't include what a slacker you are. I mean, Yale, Vanderbilt, you had a fellowship in New York, on call for the opera. I mean, I don't know what you were doing in your free time, if you had any free time. Did I miss anything? Is there anything else you want to let us know about?
You hit the nail on the head, Jenny. It's just a real pleasure to be invited to participate. And it was wonderful when I could partner directly with you in the clinical setting, but this is yet another opportunity to partner with you today. And so thank you. I'm excited to dive into muscle tension dysphonia.
Well, I mentioned that you're a laryngologist. I would bet that most people out there in the world don't know that this is a job that exists. I would love for you just to take a second and tell us what that is, what you do.
Absolutely. Yes, I often say that many people don't realize we exist. But a laryngologist, I often kind of joke that I'm an ENT, but I only focus on the T. And so a laryngologist is an otolaryngologist or an ENT physician and surgeon. And generally, we follow a what's called a fellowship training where we focus really on the larynx. And so the larynx, its main purpose is breathing, swallowing, and voice. Voice is my favorite of those three. But as a laryngologist, I take care of patients with difficulties in all of those domains. Um, and I work at UT Southwestern here in Dallas. And I've been there now, goodness, it's approaching 15 years.
Oh my gosh,
I know.
time flies.
Time flies when you're having fun.
Yeah. And so we mentioned our focus today is muscle tension dysphonia. That's a condition, again, maybe a lot of people haven't heard of. We recently had a guest on who has been managing spasmodic dysphonia. And I know that sometimes those can present kind of similarly. Maybe you can talk us through that in a little bit. But can you tell us a little bit about muscle tension dysphonia, what it is, maybe what might bring someone to you in the first place?
Absolutely. Um, our classic understanding of muscle tension dysphonia has to do with sort of a dysregulation, sometimes maybe a hyperfunction of muscle memory patterns. And those muscle memory patterns are specific to the voice box. And so, folks that may struggle with muscle tension dysphonia might present with a feeling of strain with voice use or a very hoarse voice quality. A lot of folks struggle with fatigue and meaning vocal fatigue. So they feel as though the more they talk, the sort of more tired their voice box gets in terms of both the feeling and the sound that's produced. One thing that's interesting, though, and we can delve into this perhaps later, is our understanding of muscle tension dysphonia has started to expand somewhat beyond this sort of more classic muscle based understanding. One of our speech language pathologists, Adriana Schembel, Dr. Schembel, who is one of my partners at UT, she is really doing some groundbreaking research that's helping us to understand that there may actually be more of a sensory component to muscle tension dysphonia, which is sort of amazing and exciting because I think the better we can understand muscle tension dysphonia, the more easily and more effectively we can treat muscle tension dysphonia. But it can present as kind of in two forms or fashions. You brought up your patient with spasmodic dysphonia and how there might be an overlay with muscle tension dysphonia. And that would be an example of what we call secondary muscle tension dysphonia. And so what that means is someone has a voice disorder or abnormality that we would consider to be sort of primary or the main component. And then as compensation for that, or maladaptive compensation for that, that's when the secondary tension patterns may come in. Now, there's the other variety of muscle tension dysphonia we would call primary. Primary muscle tension dysphonia this sort of classic description of someone with primary MTD or muscle tension dysphonia will have more or less a normal laryngeal exam in that the vocal folds themselves are very healthy with no lumps or bumps growing on them. We don't see any sort of neurologic spasms or dystonic sort of changes, such as with spasmodic dysphonia. And in that cohort of folks, we would um, term this disorder or this pattern as a primary muscle tension dysphonia.
So with secondary, that might be someone who had a polyp or nodule, tried
You got
to speak over that, and then develop bad habits that just stuck with them.
it. I always talk about how we really cannot underestimate the power of muscle memory. Muscle memory, with speaking voice, with singing voice, is so very powerful. These patterns can get really ingrained. And so, partnering with our voice therapist is such an important aspect of treatment for muscle tension dysphonia.
So you have within your clinic laryngologists as well as speech language pathologists who are specialized. Sometimes I think people don't realize what all speech therapists can do. They're not just helping young children overcome a lisp or something like that. Or even dealing with stroke. They can be specialized in treating voice disorders as well.
Yes, our speech language pathologists were fortunate. We have 5 clinical voice therapists with whom we partner. And my understanding is that fewer than about probably 5% of speech language pathologists actually focus on voice and have that specific skill set. So all of our voice therapists have that specific skill set in voice, and they're all singers too. So I think we speak the same language in terms of our patients who are professional voice users and singers. I think that helps us to connect. It helps us to understand the depth of the grief, the sort of grief and the level of dysfunction that can come with muscle tension dysphonia, both with and without other, voice disorders like spasmodic dysphonia, phonotrauma, that sort of thing.
Can you tell me more about the primary
Mm.
MTD that you mentioned? So if there wasn't anything physically wrong, what triggers could cause this to develop?
Yeah, it's sort of $1 million question. We don't always know exactly what will trigger this sort of pattern shift. Again, the theories are that it's muscular, but potentially may also be a sensory sort of shift. I will say that what we see in many of our patients is sometimes a psychological stressor can be a trigger. Other times, maybe an upper respiratory infection. Specifically, in that setting, the vocal folds would maybe become swollen in the setting of a cold or some sort of virus. And as a result of that, temporarily at least, while the vocal folds are swollen, that muscle tension dysphonia pattern can kind of develop. But then what's really interesting is even as the vocal folds heal and the swelling goes away and they normalize, meaning the vocal folds normalize, that muscle memory pattern sticks. And so that would be another example of, it's hard to say that's actually a pure primary, but at least a lot of times by the time I would see them in clinic when they're over this infection, the exam looks normal, but the muscle memory pattern is still not as efficient, not as efficient as it used to be.
What kinds of things would they be doing that are actually setting up less than helpful muscle memory?
The sort of classic description is a hyperfunctional pattern. And so when we look at the voice box, we're looking at not only the vocal cords, which we call the true vocal folds, but we're also looking at the paired muscles surrounding the voice box on the inside. And classically, what's described is Sometimes we'll see what are called the false vocal folds, which are the tissues just north of the vocal cords, squeezing in, really, really squeezing in and sort of constricting on top of the vocal folds. And what's interesting is that's the quality of the sound that we hear as well. Often it'll sound tight. It'll maybe sound like the sound like it's being strangled a little bit, squeezed. And our patients will often feel that speaking takes effort. It feels tight. They're tired after they've been talking a lot. So that's one of the most typical things we'll see is just, again, that squeezing or constricting of the tissues just above the actual vocal folds. Sometimes we'll also see the vocal folds themselves really come together with a fair amount of force. Sometimes we'll see in really, really severe cases, there's a slightly different name for it, functional aphonia, which is sort of on the most extreme end of the spectrum. In those cases, sometimes we don't even see the vocal folds come together all the way. We just see the squeezing of the tissues just above the vocal cords. And that is the most severe presentation where our folks basically have zero sound. They're unable to produce a sound. So, this spectrum definitely exists, but I would say the most common thing that we'll actually see on our exam is that squeezing pattern.
I've worked with a couple of clients who have this diagnosis, and I'm sure you've discovered this as well. As you're going through the history with patients, is that sometimes I'll find that they don't even remember what that trigger was. But as we keep asking questions and keep digging, they'll say, oh, well, I was sick maybe 2 years ago and I had this tickle in my throat that wouldn't go away. But my job is very talking heavy. So I try to control my throat to keep it from tickling. So they're really bracing themselves or trying not to cough. They're kind of holding back the cough. And then, as you said, they've gotten over that sickness. They don't have the tickle anymore, but those patterns are still there. They didn't even recognize what would have got them to this point. But as you dig, you start to find out maybe that was a triggering event.
Oh, absolutely. Absolutely. And even in those situations where maybe it was some sort of psychological stressor, a lot of folks, it's really interesting. We'll talk about how they feel so tight, like that same tightness they feel when they're about to cry,
Oh,
And I know,
in your
right?
throat where you're kind of like holding back. Yeah.
Yeah. Yeah. Right. It just feels like it's like a vice grip. Janice Dean, who was one of my fabulous partners, who has since retired and is living her best life. But she would always say, and I don't know if hopefully I won't be misquoting her, but she would say, the larynx, the voice box is like an emotional sphincter. And it sort of sits right between, the head and the heart, and it's ruled by both. Right. And so, anyway, all that to say, I don't mean to get off track, but, I think another example of a trigger is, the death of a loved one, a divorce, some sort of loss of a job or something like that. Folks, I think when we dig, like you said, sometimes we will come upon, aha, yeah, it does seem like after that my voice changed, and things just haven't been the same vocally.
Do you find that sometimes there's a perfect storm? There was stress. I was also sick. I also had to do a lot of talking. I was stressed, so I wasn't sleeping. Maybe there's a combination of things that just set them down this path of maladaptive use, as you were saying, of those muscles.
Absolutely. Yeah. I would say that's probably the most common thing is it is the storm of everything happening at once. In this day and age, we're all too busy, and we rush around and, so again, I think that is probably the most common thing is that it's many, many things happened at once. I had a cold and I had to audition for this, that, or the other, or, in fact, I will see that sort of perfect storm with a lot of my voice patients, right? My phonotrauma patients as well. So it's a common theme that makes it a little bit more difficult to be able to kind of parse out exactly what it what it was that may have triggered. But again, I think it's typically a combination of things. And the hard part is we don't have a way of being able to say specifically, aha, it was this, that led to it. But I think trying to understand what may have contributed to the development, I think that's useful because as we improve and become more efficient and those muscle memory patterns are retrained, um, the hope is that moving forward, we won't kind of set ourselves up for the development of another episode.
Understanding how to use your muscles better can keep you from repeating the same pattern
That's right.
that got you there in the first place.
That's right. And even sort of the life events and circumstances, right? Like, oh, I remember the last time, I was in this super stressful time of my life. And then, this started, right? Okay, let's see what I can do to manage all of these other things in my life so that hopefully, that stress level doesn't go quite as high, sort of thing.
Do you see this most commonly in a certain population of patients, like a certain career? Do you see it mostly with singers, or is it something that could really impact anybody?
It's a very good question. Not necessarily more in singers. I think generally speaking, in our clinic, we see folks who rely on their voices more, and so our professional voice users, call center folks, and our teachers, preachers, anyone who is relying on their voice, I think is more at risk for developing any sort of, well, should I say more at risk? Maybe not more at risk, but perhaps in some ways more at risk, but also certainly more sensitive to any sort
Sure.
of, handicap or level of dysfunction. So it's probably a combination that in some ways, just because of that amount of use, they're more at risk for developing something, but also, as I said, they're more sensitive to any sort of voice changes.
You mentioned that you had to go see a laryngologist when you were
Yes.
in high school. What symptoms were you experiencing? If you don't mind
Yes.
sharing, maybe it's personal.
No. No, not at all. No. I was on my way to a competition, like a voice competition with several of my classmates. I was on the bus, sitting in the back of the bus, just talking away, probably yelling and screaming, And I lost my voice on the way to the competition, which means I whispered through the competition. I did not end up doing very well. um, so, all that to say, after that, it was my choir director that said, you know what? You should go visit this otolaryngologist in Austin. He has since retired, but she was known for being sort of the ENT that took care of a lot of the singers and professional voice users around town. So I went to him, and yes, this is when I was in high school, and he was lovely. And I had my first laryngoscopy. Fortunately, it was swelling, vocal cord swelling, and nothing more. But I remember looking around his office, and he had some photos up of various performers who he had cared for, who said, thank you for, helping save my, my final week on tour or whatever. And I looked at him and I said, you know what? I think I'd like to be you when I grow up. And it was really kind of neat because then my career day when I was a senior in high school, I shadowed him. When I matched for residency, I wrote him a letter. I've since written him another letter. I think it was after my fellowship. His wife wrote back. He was sort of not able to write me back at that moment. But anyway, it's just a really neat thing how he inspired me and he was kind. I owe a lot to him.
It's interesting you mentioned kindness. What I have found is that anyone who's struggling with their voice, especially if they rely on it for their job, their livelihood, or it's so tied up with who they are. I'm a singer, I'm a performer, I'm a radio host. When something happens to the voice, it's like it really shakes their sense of self, sense of purpose.
Mm-hmm.
If a stress event is what triggered the tension in the first place, then this added stress of what does this mean for me, for my livelihood, seems really difficult to overcome.
Absolutely. I often say that the voice is the most personal of all art forms, and it's sort of inextricably linked to self-identity, right? That is how we present ourselves, one of the ways I should say that we present ourselves to the world, that we connect with others, that we commiserate with others, empathize, right? All of these things we do using our voice. Yeah, there are many, many tears shed in my office. It's a really, really vulnerable space, I think, especially again, as you said, the stakes couldn't be any higher when our livelihood depends on it. This isn't something you can sort of look at like a violin, right? And be like, oh, I just need to get this tuned, or I just need to get this, string restrung, or I need an upgrade, right? I just need to trade it in. No, this is the one and only set of vocal folds we have, and the level of grief associated with any sort of difficulty with the voice cannot be underestimated. Again, I think because of that personal aspect, the fact that we are the instrument, and it truly is how one of the main ways that we connect with others and make money too, many many times.
Right. So you were telling her your story about being in high school and going in to be scoped. Can you talk us through that process of diagnosis? From a patient's perspective, what can they expect? What does the exam look like? What are you
Yeah.
doing to them?
Yes. Well, that's a great question because I think there's probably an element of fear with it sort of unknown. How in the world are they going to look in there?
Right.
How is this going to work? So yes, when our patients come in, we often will schedule our voice patients both with me or one of our other two amazing laryngologists, and with one of our voice therapists same day. Insurance universally pays for that initial evaluation, so that's why we sort of take the opportunity when we can to get folks scheduled for both. Simply because so many of our voice patients do benefit from the voice therapy intervention. But anyway, they'll come in and I will meet with them first. Typically, we have them read a passage called the Rainbow Passage, has all the sounds in the English language in it. It's used at voice centers all around the country. And then we look. And so the way we look at the vocal folds, and this is, of course, after getting a comprehensive history and having our patients share their story, but we can look at the vocal folds two ways. We can go through the nose with a flexible scope, or we can go through the mouth with what we call a rigid scope. And if we go actually in both approaches, we can numb. We typically numb the nose when we're going through the nose with a flexible scope. Think of it like a spaghetti noodle um, going through the nose, peeking over the back of the tongue. With the rigid approach, it's through the mouth, and I gently hold the tongue and kind of again peek over the back of the tongue.
Patients are awake, right? They are awake.
Yes, yes, they are awake and alert, and we record the whole thing. And so I think one of the best parts is being able to look at it together and sort of talk about what we're seeing after the exam is finished. But once we have a view of the larynx, then the idea is to kind of do a little bit of vocal gymnastics with our patients. So we'll have folks sustain a vowel like an E vowel. Sometimes we'll do glides. Sometimes we'll have people go way up high, way down low. Basically, especially if there's a certain area of their range or a certain sort of voice quality that's kind of upsetting to them or they're struggling with, that's what we want to see during the exam. And then after the exam, as I said, we'll review it together. Oftentimes, the voice therapist will be in the room during all of that. So that way, we're all on the same page about why our patient came to us and what they're struggling with. And then we'll talk about the findings of the exam, talk through various treatment options. And then I usually get out of the way one of the most important parts of their therapeutic plan can begin, and that's the work with our voice therapists.
So they actually get to see on camera, on a monitor, what you are seeing, and you can point out to them anything that you're noticing that might be unusual or what's working well. What's their reaction when they see their vocal folds for the first time?
I mean, usually it's like, whoa, I had no idea. I mean, it's rare that I'll have folks like think it's gross. Most of them are just fascinated, super fascinated. Like, I envision something totally different. It's lovely. That's one of my favorite parts of the exchange that I share with patients is sort of this magical moment where they get to see their own instrument, for the very first time. So it's really neat. Most people just love that moment.
Once they get this diagnosis and you lay out for them some options for treatment, they're seeing you or they're seeing the voice therapist, or what is the follow-up like once they get the diagnosis?
Typically, voice therapy is sort of the workhorse in terms of the main thing that will be recommended in terms of treatment.
And why is that?
Mm, because so much of their recovery process is what I would call behavioral. And that, what I mean by behavioral, it's typically more about the muscle memory retraining and what we call laryngeal unloading, which is just a fancy way of sort of taking the tension and strain out of the voice box area and really emphasizing proper breath support and forward resonance, all of those wonderful things that help reduce the amount of strain and tension. So the voice therapy, that's really where you learn how to do all those things. And I think, as we've talked about before, I do make a lot of analogies to athletes because I think it's helpful for folks to sort of better understand our team and the dynamics. And so you can think of a voice therapist as like a physical therapist for the voice. Okay. And so, if there's an injury or some sort of inefficient pattern, muscle memory pattern, muscle strain, we're going to have you work with the voice therapist, AKA physical therapist, for a period of time, whether that's 3, 4, 5, 6 sessions, something like that. And I would say kind of a ballpark average would be 4 to 6 sessions, but some folks kind of extend their training beyond that. But then I will see folks back after they've had, at least a few voice therapy sessions. And the idea is to then get a sense of where they're at and how they're doing. How have we improved? How is it feeling with voice use? How is the stamina? Has the quality of sound that's produced improved? All of those things is what we're looking for. And as we see these folks back. And that's specifically for those with the primary muscle tension dysphonia. For those with the secondary muscle tension dysphonia, it's interesting because as I say we, but it's really our voice therapists are working their magic to unload the excess tension and retrain muscle memory patterns. In the cases of secondary muscle tension dysphonia, sometimes we'll see that primary, the underlying issue, whether it be a neurologic voice disorder like spasmodic dysphonia or some sort of phonotrauma, so vocal fold polyp, vocal fold nodules, sometimes we'll find that primary issue becomes actually in some ways more apparent, if that makes sense. But I often will sort of reassure my patients that that may happen, and if it does, that's okay. Because that means we can then focus on that primary issue and then hopefully get that part improved. But when we have this sort of overlay, this secondary muscle tension pattern, it makes it really hard to get that primary issue improved, if that makes sense.
So I'm imagining a patient I saw once who had nodules. I believe she had had surgery, but she was a singer. Because her habits were not great, there was a high risk of her having a recurrence of something like nodules in the future because part of why she developed the nodule in the first place had to do with the way she was using her voice. So it sounds like primary, secondary are really hard to tease apart sometimes. So maybe it was the muscle tension that was leading to poor use that leads to this physical change
Mhm.
And if we don't fix the underlying reasons for that starting, it could very well repeat itself.
Hmm. You're right. Yes, that interplay can be the chicken or the egg thing, right? It's hard to
Right.
know exactly which comes first. But yes, it's typically kind of the combination. So with the nodular patient, we'll use that because I think that's a great example of someone will often see a combination of some muscle tension patterns that are less efficient or maladaptive. But then we also have this tissue change, right? The callus is on the vocal folds. And, often with nodules in particular, we talk about this concept of vocal dose and the kind of reduced how much you're speaking and how loudly you're speaking, right? And so that's a little bit different than how you're actually producing your sound, right? And so you're right. It's sort of all of those issues combined. But with your spasmodic dysphonia example, sometimes the reason for the muscle tension pattern is to sort of guard against those spasms. And so as we get rid of that muscle tension, those spasms can become more apparent. But the beautiful thing is, once we treat those spasms, like with Botox, for example, the voice is so much better. Because if we treat the spasms without addressing that overlay of muscle tension, then the muscle tension typically sticks around and the voice doesn't improve as much, if that makes sense. It's like peeling an onion, a layer at a time.
It does make sense. So, with spasmodic dysphonia, as people may remember from our interview with Jeff Piquet's, the voice is kind of cutting in and out. And we may be using our muscles to try to minimize that, to take
That's right.
control over the voice.
Yes.
So, even if you were to treat the spasmodic dysphonia with Botox, if those habits of tension are there, you still may have a strained, strangled kind of sound, but not because of the spasmodic dysphonia. It's the way you're using the muscles around and in the larynx.
That's exactly right. That's exactly right. So it's tricky because one would hope that once those spasms are treated with the Botox, for example, that secondary muscle tension pattern will just fade away.
Because the voice is easier.
The voice is easier. And I will say that does happen sometimes. So it's not always the case that the voice therapy intervention is so very, very crucial. But I will say it's far more common. Again, I think because of that power of the muscle memory, it's really hard to, we talk all the time. We take our voice for granted. We don't think about how we talk, generally speaking, right? And so I think that just kind of underscores how important the behavioral work is because these shifts in muscle memory are rarely automatic. They need a more intentional sort of intervention, and that's where our behavioral voice therapy work is so important.
So you have done a couple of studies on muscle tension dysphonia. Can you tell us a little bit about what you were examining?
Yeah, and this is where I'm not a voice therapist, but I know sort of the bare minimum of some of the more common approaches into kind of laryngeal unloading, which is again a fancy way of saying kind of reducing some of the tension patterns that we can see. There is one voice therapy approach called stretch and flow and another resonant voice therapy. And so some of the work we've done was sort of looking at both of those and trying to see if there's any obvious difference in effectiveness with one versus the other. And we found that they both seem to be very effective. And I will say, I think in reality, our voice therapists generally combine both of these and other approaches. A lot of it has to do with, stimulability, meaning how do our patients respond? Do they seem to improve with one approach or one strategy versus another? Can they feel a difference more with one style or one approach? So anyway, just to summarize our work, I think it was more or less helpful in kind of establishing that a couple of very, very common protocols can be effective with muscle tension dysphonia.
It's so wonderful to have that study as a voice therapist, to be able to look at that and know that, okay, I'm on the right track.
Yes.
I'm not giving my client a strategy that hasn't been proven, or because I chose this one over this one, I'm not doing them a disservice. What I've found is that there is a lot of experimentation to see what as you said, stimulability, what do they respond most to?
Mm.
And sometimes I find that stretch and flow, for example, a lot of my clients don't like it, and they won't practice. So part of it too is trying to figure out with them, which of these will you actually do when you leave the office today? So
Right.
we can build a practice routine, because part of changing muscle memory, and maybe you can explain this, is that it does take practice. It's not something you can just do when you go into your session. It takes a lot of rewiring to make the
Mhm.
changes. And the only way to do that is to spend a little bit of time every day practicing these exercises that you're being given, so that you'll start to see improvement. Is that what you see as well?
Absolutely. And I think that rewiring is such an important way to describe it. These are not automatic. And especially at the beginning, I know our patients will talk about how it just feels, first of all, very foreign to do some of these
They're
things
so
that they're
weird.
being asked to
Unless you
do,
were an
right? Like,
actor or a singer, they feel
yes,
so weird.
super weird. And it's also, I think, sometimes kind of hard to understand the why. And that's where our voice therapists are. And you, Jenni, I know you're in the same group, right? You guys are just amazing at sort of slowing down the process and distilling things down for our patients so that they can really understand that why. Because at first glance, why am I blowing bubbles and why am I using a straw? Like, but there's actual science that backs these approaches, right? And all of that to say that the voice therapy process is something that does require a real commitment in the form of a discipline. This is a daily, we're rewiring, as you said, we're sort of relying on some neuroplasticity and sort of retraining these and really well ingrained patterns. And without that sort of daily commitment, that last step of translating to conversational speech is the biggest hurdle of all. And I think without that commitment, it's difficult to get to the point where it can shift to a more automatic experience.
That's a really great point. That shift into conversation. Like, we don't want you to just be doing the exercises alone. That's great if you can do those and sound good.
Right.
But the hard part is
Yes,
getting over the hump and being able to do that without focusing on it so much.
exactly. Because we don't want our patients to need to think about how they're talking forever, right? I mean, we want it to become a new pattern that then feels automatic. And so that's sort of the ultimate goal is, they look back, they barely even remember this period of time, and they have these efficient patterns, and their voice is able to function exactly how they're hoping it will for them, depending on their need.
I think your comparison to athletes and physical therapy is perfect for this. An athlete didn't make a mistake and that's why he pulled his shoulder. Like, it's not your fault necessarily that this happened.
Mm.
It happened. And then there are strategies to help you get better. Maybe, if I'm thinking about a pitcher, your habit, because it has worked for you, is to pull your arm way back before you throw it. With the physical therapy and maybe a coach on the side, you might make adjustments to how you've been doing it, because it's going to help you have a longer career.
Mm-hmm.
And you might be slower at first,
Hmm.
but ultimately, these new habits are actually going to make you better.
That's right. That's right. Make you more efficient, right? We're focusing on longevity. We're focusing on vocal stamina. This one set of vocal folds, we want to kind of last you a lifetime. And so we might have to bench you for a little bit. By benching, what I mean is, do we need to do a short period of voice rest? We may need some medical intervention, whether that's steroids, not necessarily in the setting of primary muscle tension dysphonia, but if we have a lot of swelling and things at the level of the vocal folds, sometimes we'll have folks take steroid pills, and usually we pair that with voice rest, right? So that's the medical intervention. Our athletes will sometimes get steroid injections. We'll actually inject the vocal cords sometimes too with steroids. So yes, so many analogies with and our singers or professional voice users, they are vocal athletes, right? Or vocal acrobats, however you want to say it, right? We talk about warming up and cooling down. vocal hygiene is all about the water and the, hydration, and all of those things can be analogous, as you said, or as we've talked about, to an athlete.
I'm really interested in this sensory path that you guys are taking a look at. I'm thinking of a client that I have now. Every time he talks to me about what's going on,
Mm.
when he starts to feel discomfort, he starts to feel pain. He also describes this kind of wet sensation. And he's the one I mentioned had a memory of this all starting with a tickle that he couldn't get rid of. And it made me think of chronic cough. How are you exploring this idea of maybe it's a sensory issue?
Yeah. Well, and I don't take any credit. It really is Dr. Schembel who is leading the way on this groundbreaking research. And, my kind of surface level understanding of what she's doing is first just trying to ascertain whether there's a difference in levels of sensation in folks with muscle tension dysphonia and folks without. And so one of the ways that we are assessing that is actually using a laser at very, very low settings to get a sense of how the larynx and how they are perceiving this sort of stimulation from a laser fiber in their voice box. And trying to ascertain, is there a difference in kind of how much our MTD or muscle tension dysphonia folks are perceiving this sort of sensation versus those who don't have muscle tension dysphonia. And they're seeing some differences. And so it's something to kind of keep your eyes and ears peeled for, because I think it will likely really help us to better, like I said, understand muscle tension dysphonia, and then eventually inform how we're treating it. As far as exactly how to do that, it's hard to know. I will say, for example, with chronic cough, we do nerve blocks for the superior laryngeal nerve to reduce sort of the sensitivity of the main sensory nerve. And a lot of those folks do feel a tickle or something, in their throat or right before they cough or right before they clear their throat. So I don't know if something like a superior laryngeal nerve, which is the main sensory nerve to the voice box, if some sort of intervention on that nerve might be, a part of the treatment protocol. It's hard to know. But I think at this point, the main focus is more trying to identify, is there a difference in sensory thresholds for patients with muscle tension dysphonia versus without? And then, the next steps are yet to be discovered.
How do you get volunteers for that?
Oh,
If you don't have muscle tension dysphonia and you just want to help, you go in and you get your vocal folds lasered.
I know, right? Good news is, so good question. We want volunteers who have muscle tension dysphonia and who don't. And rest assured, the laser is not actually touching the vocal cords at all. It's just touching the arytenoid. So it's just a little tap, a little bit of laser fire, so to speak, not an actual fire, but just a little beep on the tissue overlying the joint that moves the vocal fold. So the vocal fold itself there's no laser exposure there. But there is compensation, so that helps. So they get paid, those who participate. And even more importantly, it's a noble act of kindness and to help us better understand this disorder so that, in the future, we can more effectively treat it.
You mentioned Botox for spasmodic dysphonia. Do you use Botox for primary muscle tension?
Sometimes we do. I will say the times that I've injected Botox in the case of muscle tension dysphonia is usually in those really severe folks with the more functional aphonia component, meaning they really have no voice at all. And the squeezing pattern is very, very severe. So what I'll do in those settings sometimes, after we've, pursued voice therapy, if we're still really struggling, sometimes injecting Botox into some of those tissues north of the vocal folds or above the vocal folds will weaken them temporarily. And that can really, really help sort of, I call it a kind of like a Control-Alt-Delete for the voice box. It's like a laryngeal reset. It can be quite helpful in sort of getting folks to, in some ways, we're sort of chemically resetting things, right? Because Botox works through neurotransmitters and things like that. But it's not generally our first line of defense, but it can be helpful in really severe cases.
So you work with speech language pathologists. We were talking earlier about how this can be a very emotional, stressful time for your patients. Are there other professionals that you work with? Do you recommend psychology, working with a therapist? How do you help them with that aspect of it?
Great question. So we generally talk about how we approach our patients in some sort of a team perspective. And so along with the laryngologist and the voice therapist, we do partner with an actual physical therapist or physical therapist who will do, generally we call it myofascial release, which is again, I'm not a physical therapist, but it's deep tissue release maneuvers that can be very, very effective for folks with muscle tension dysphonia. And then absolutely, we partner with psychologists often because of that sort of inextricable link to self-identity and sort of the trauma and the grief that can come along with this. A lot of times our folks and really benefit from working with a psychologist or therapist, sometimes a psychiatrist, just to help address that real mental health component to these folks struggling with voice disorders.
And you used the word grief earlier to describe what some of these patients may be going through. Can you talk a little more about that?
Yeah, I mean, I think this is a real burden for folks, not only because they don't feel like themselves anymore, but I think also they get the sense that they're judged by the rest of the world, right? That they're dismissed, that assumptions are made about them that are unfair and untrue. You know, from a professional standpoint, folks can really end up losing clients, losing business, losing, kind of professional respect, even. And, at least that would be their interpretation. I have patients who'll sometimes talk about how, they used to be able to command a room with their voice, right? Especially my older male patients who have thinning vocal folds atrophy is the medical term for that. They'll say, gosh, I used to walk in a room and the moment I said one thing, all eyes turned, and so it's a real curveball that these voice disorders can throw our patients, and it hits them to the core. It really hits them to the core.
Is this something that shows up suddenly? I mean, when you say a client like that, let's say, who used to walk into a room and everyone would turn, do you find that it's something they've noticed that's kind of gradually gotten worse? Or is it like, hey, I don't know what's going on, out of the blue, I just don't sound like me?
Generally speaking, it's more progressive. It's more subtle. It's not a sort of light switch experience. More often than not, it's sort of over time. I will say folks, for example, who experience a change after a breathing tube is placed, for a surgery or after illness, upper respiratory infection, those sorts of things can be a little bit more abrupt in their onset. Generally, it's a little bit more progressive, I would say.
As those maladaptive behaviors start to become entrenched.
That's right. That's right.
It's funny. Sometimes I say voice is really counterintuitive. The harder you work and push, actually, the worse it sounds. And
yes, I often say, the hardest thing to learn is to get out of our own way.
Right. Do less. Do less.
Do less. Right. And kind of, yes, I think the rebalancing, Amy Harris, as you know, Amy, she talks about rebalancing the vocal subsystems. She's an amazing voice therapist. And I love that expression because to me, it makes sense, right? We're talking about the subsystems of the breathing apparatus, which is our power source, the vibratory apparatus, which is the vocal folds, and then the resonating tract, which is basically everything north of the vocal folds or above the vocal folds. Rebalancing those is sort of the overall goal with voice therapy.
It's so fascinating to me, because you're probably the same way. You've lived it for so long. And then you have clients come to you who have no idea about how their voice works. As you said, they never thought about it until there's a problem. And so I feel like part of, maybe hopefully this podcast or the work that we do out in the world builds awareness that there are things you can do. You have a pretty good amount of control over your voice. It's just nobody's ever taught you how to do it unless you were a singer or an actor.
That's so true. Yes. And I agree. The more of this awareness of the fact that there are people like us in the world, the more we can raise that, increase that awareness, the better. And that's where World Voice Day, I know that it's coming up.
That's right.
Yes. And that's, I think, a wonderful opportunity to just really underscore the idea of taking care of our one and only set of vocal folds. And if there are difficulties vocally, know that there are places you can go, and there are people who can help that have been trained to do exactly that, to help you find your voice again.
One rule of thumb that I have heard, I want to make sure that this is accurate, is that if you're experiencing hoarseness for 2 weeks, you should get checked out. Is there anything else people should be on the lookout for? And is that even accurate?
That's spot on, Jenni. As usual, you are right on it, right on the latest evidence. So yes, generally speaking, I think 2 weeks is an appropriate metric. 2 weeks of persistent hoarseness. And so generally, I talk to my patients about, especially my singers, for example, is it impacting both singing and speaking? That's more worrisome than if it were, for example, just impacting singing voice. Not that that's not worrisome, but when it's impacting both, we really do want to make sure we don't wait too long. And that 2-week window, I think, is appropriate. Ideally, going to a voice center and for that sort of evaluation and what's called video stroboscopy, which is the fancy way of saying looking at the voice box with that flashing light to see the vocal folds vibrate so that we don't miss subtleties. A voice center that has partners in voice therapy is really ideally where you want to go. Some folks, though, they can't make it all the way to a voice center. So going to a local otolaryngologist, a local ENT, a lot of them have the ability to look at the vocal folds, maybe not necessarily with the stroboscopic light source, but it's a wonderful sort of first stop and a wonderful opportunity to at least kind of be generally screened. And then if necessary, they'll often refer away if there is something that's identified that needs attention.
How many laryngologists are there in the States?
Oh, wow. Gosh. Oh, I don't have those numbers off the top of my head, but I will say it's a relatively small community.
That's what I was thinking.
Know each other, and most major cities and kind of cosmopolitan cities have voice centers. There's several even in the Metroplex here.
It's impressive. We are spoiled, I think, in DFW.
Yes, we are. The good news is we all are very busy. So there's no lack of folks who can benefit from us. And we all partner together and share patients every once in a while too. And it's a nice community.
A follow-up question on your Disney work, for those who've been just dying for us to get to this. Can you tell us a little bit about how did that come about? Where can people hear you?
Oh, my goodness. Well, I think I've aged out. This was a while ago. This was when I was in college and medical school and a little bit at the beginning of residency. I was just very fortunate. I had a friend of mine who sang in choir with me. I was at home over the summer in Austin, said, "Hey, Disney's in town. They're auditioning. They're looking for princesses. You should go." And it wasn't like an in-person princess. It was just a singing voice sort of thing. And this friend just thought, maybe I could try. And I was like, okay, why not? I didn't have an agent or anything like that. And anyway, I got the gig. So I recorded at that point, and it was all just recordings for some of the vocal tracks for karaoke series. And then it kind of expanded into a little bit more of kind of some Princess Tea Party recordings. So over that period of, 6-7 years, whenever they had sort of things that maybe would fit my voice type, they give me a call. And so I did a little bit of recording in Austin and New York City and Nashville. And depending on where I was and where the Walt Disney Studio records, kind of recording studios existed. So it was a lot of fun. It was a lot of fun. But yes, I will sometimes joke that maybe the occasional like 4-year-old or 5-year-old may hear me at some point, but it's been a long time since I've done that, but it was really, really fun and a wonderful, wonderful opportunity.
Well, you have 2 daughters, right?
Yes, I do. I do.
What was their reaction when they learned this about you? Have they been able to hear you?
It's so funny. We would be driving in the car and be like, oh, that's one of the ones I did. And I think the girls, they probably, I don't think it really fazed them. I think they were just sort of like, okay, well, that's mommy singing.
That's just who mom is.
Exactly. But I think now that they're a little bit older, I think they understand it a bit more. But
Do you still sing?
I do. I do. I was taking lessons up until somewhat recently, and I need to get back into lessons because I kind of feel like, I got to work through the cobwebs. But I was classically trained, as you said earlier. And most recently, I was really working on sort of exploring my chest voice. And it's amazing how that sort of working on that part of my register actually helped the upper sort of more classical high soprano stuff open up too, which was really, really cool. I'm a big believer in continuing to sort of train and practice at your craft. Fortunately, singing is a lifelong sport, so I need to get back into it.
It's funny. Side note here, I did a play. It's been a couple of years ago now, but I had young children at the time, so I hadn't been on stage in a really long time when I did this show. And I forgot how physical speaking can be. Filling a space, the control you have to be able to use your voice. I mean, just being in shape enough to have good breath control. I was shocked and had to really hustle and get back into those really good habits of warming up every day, doing something every day to be able to get through a run.
Absolutely. Absolutely. I bet that was amazing to be back into it because I know you are an actress, a very, very talented actress. And I'm so glad that your daughters were able to see that too. That's
They actually
special.
were not allowed to see that show. It was a little heavy. It was a little heavy. So I don't think they've seen me on stage. So I need to get back out there at some point.
For sure. That would be incredible for them to see you.
I cannot thank you enough for taking time on your Sunday to come in and talk with me about these issues. I so appreciate it. I've been dying to get you on, actually, just shed some light on some of these disorders, conditions, things that people are dealing with, just to know that there are resources out there.
Yes.
And that they're kind, understanding doctors out there who can help you when you've been to all kinds of other doctors. They just put you on allergy medication or who knows what to try to get you through it. That it might be worth looking a little bit more deeply into with someone like you.
Well, I appreciate that. And I'm grateful to you for increasing our awareness, right, of this sort of voice disorder and many others. So thank you. And I certainly appreciate the opportunity.
Well, it's great to connect to you again. So thank you for that.
Yes, absolutely.
Thanks so much for joining me on Speaking of Talking. If you loved this episode, I'd be so grateful if you'd leave a review, share it with a friend, or send it to someone who geeks out on voice just as much as we do. For more tips, tools, and behind-the-scenes goodies, head to the show notes or visit us at jennisteck.com. I'm Jenni Steck. And remember, your voice isn't just how you sound, it's how you show up. Own it, trust it. And let's keep talking, because we've got a lot to say.